Good afternoon, everybody. Good morning to others and good evening to some of you. It is our pleasure to welcome you to this second ITM alumni webinar, which will be focusing on the social determinants and the national response to the COVID-19 pandemic in Ecuador. In the series of ITM alumni webinars on COVID-19, ITM alumni present their impressions on the current situation of the outbreak in their country and highlight how they are engaged in this global fight against the pandemic. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now give you a brief explanation of some webinar practicalities. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. Questions will be moderated and only a select number of questions can be discussed given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. You can, however, use the forum function in the online alumni platform to start a discussion on your questions left after this webinar, and of course also follow the next upcoming webinar, which will be organized on the 6th of May. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM YouTube channel. You will get a link through email together with the announcement of the next upcoming webinar. Our today's moderator is Professor Dr. Lutlijne. Lutlijne is a medical doctor specialized in internal medicine. She has been working for MSF Belgium in Chad, Sudan, and Guinea. She works for the Institute of Tropical Medicine since 1999, first in Cambodia, and then afterwards, since 2003, she joined the HIV team at ITM in Antwerp. She has been a member of the WHO Guideline Development Group on Opportunistic Infections and is the author of the MSF AIDS Care Guidelines. Her field of interests is HIV, TB, and clinical decision-making, with a focus on resource-limited settings. Since July 2011, she is head of Department of Clinical Sciences at ITM, and since November 2011, also head of the units HIV and TB. Lut, please.
Thank you, Charlotte, for the introduction. If I had known that you were going to read it all, I would have made it shorter. Okay, it's my pleasure to welcome you all. I'm very happy to be here. And I would like to introduce our speaker of today, who is Rodrigo Henriquez, living and working in Ecuador. He is, I know Rodrigo since 2009, when he was a student at ITM in the short course on clinical research and evidence-based medicine. And in fact, the year after already, he became a facilitator and a tutor and a teacher in this course. So he's coming now every year because he is an expert in evidence-based medicine in his country. Rodrigo is an associate professor in the research group of One Health in university, which is a university, let me see, Universidad de las Americas, I hope I used the right accent, in Quito, in Ecuador. And he is in fact involved in his country very often in guideline development for clinical practice. He is specialized in family medicine, and so also now in the response for the Corona epidemic, he is as well present in many of the technical working groups in his country, trying to build consensus on diagnostic and treatment guidelines for COVID. So we are very fortunate that he is today willing to share his experience with us. So Rodrigo, please go ahead.
Greetings to everybody. Thank you for the invitation. I'm very happy to share with you our experience dealing with this COVID-19 pandemic in Ecuador. Ecuador has been described during the past weeks as an emerging epicenter of this COVID pandemic in Latin America. This corona outbreak has overwhelmed emergency services, hospitals, and also the funeral parlors. And in particular is the second largest city in the country, called Guayaquil, one of the most affected. And more than 68% of all the cases of COVID-19 are there. So in this webinar, I will focus in the role of the social determinants in disease transmission, their influence on how to maintain public health measures like the lockdowns and quarantines, and also the discussion around social determinants of health in how to maintain the lockdown, but also this trade-off between the lockdown and public health measures and the need to resume economical activities. We're gonna talk also a little bit at the end of the presentation on how to deal with the fast elaboration of clinical consensus on diagnosis and treatment, especially because the plethora of non-peer review literature and information. And we're going to discuss also how to increase the diagnostic capacity of the health system to identify, isolate, or discharge the suspect, because this is now a key issue in countries like Ecuador and probably everywhere in the rest of the world. So let me start with a short timeline. We already know the origin of this pandemic the last month of 2019 in China. But for us, it's important to discuss when the problem started, not only in China, but also in Europe, especially because Ecuador has a large population of immigrants living in countries like Spain, Italy, and also in the United States. In countries like the United States, we have more than 1 million Ecuadorians living there. In countries like Italy and Spain, we have more than 300,000 immigrants living in each of these countries. So the direct relationship between travel from those countries to Ecuador was also a key issue in the starting of the epidemic in countries like Ecuador. We face the first suspect patient coming from the province of Fujian in China during the third week of January this year. This suspect patient was really a problem because he has all the symptoms, he has all the criteria for a clinical diagnosis of COVID-19, but all the tests were negative. This patient sadly died on February 8th without a diagnosis. Several diseases were ruled out, and we still have the suspicion that this was the really first case of COVID-19 in the country. But the first case confirmed by laboratory test, we have it on February 29. This was a 71-year-old female patient living in Spain, was an Ecuadorian woman living in Spain, and she came to visit her family in Ecuador. During their visit, she traveled to several cities around the country, in Guayaquil, in Babahoyo, in Quito, and this case was responsible probably of the transmission to the disease to at least 15 different persons. From then, we have the evolution of the epidemic at the country. The 11th of March, the national sanitary emergency was declared. Also, the WHO declared the pandemic. The 13th of March, we start with restriction of massive events like soccer games and also closing schools. Then we increase the lockdowns. We have partial lockdowns to avoid the mobility of the people within the cities and also between the provinces. The situation increased and the number of patients was rapidly increasing, especially in the main harbor in Guayaquil. I will discuss about that in a few minutes. But the situation was really difficult. And in March 21, the Minister of Health resigned. And in her resignation letter, the minister complained that the government had not allocated enough budget to face the emergency. What is the situation now in Ecuador? These are numbers from 3 days ago. In April 19, we have more than 9,000 cases confirmed, but we have also a lot of cases with clinical suspicion. And one of the main problems we have right now is that we don't have enough capacity to run diagnostic tests to confirm all these cases. So we'll still have more than 11,000 tests to run. The samples are taken, but we have a bottleneck in our national reference laboratories, and they cannot process all these samples fast enough to confirm or discharge the cases. So far, we have more than 1,000 deaths. 478 deaths are confirmed by laboratory tests, and 800 cases are deaths due to suspect cases of COVID-19. As you can see, this is one of the daily reports that the government provides. As you can see, we share information about the confirmed cases. This is from April 20. We have more than 10,000 confirmed cases, more than 500 deaths, confirmed deaths using laboratory tests. And as you can see, Guayas province, where is Guayaquil, one of the biggest city, the second biggest city in the country, has received most of the cases. We have more than 68% of the cases located here in Guayas. Let me show you with my pointer here. We have more than 6,000 cases already confirmed in this province. The rest of the cases are located in the capital city, Quito, which is in the province of Pichincha. As you can see, most of the confirmed cases are in the ages between 20 and 49 years old, and most of the deaths are in the province of Guayaquil, in Guayas. Also, you can see this curve, this epidemic curve, and this curve is misleading because we see a flattened curve, but in reality, this curve reflects that we don't have enough capacity to do test and confirm cases. And probably we have many more cases, but we don't have the possibility to confirm these cases. So when we talk about social determinants and their influence in the healthcare response to COVID-19, we have to take into account that there are different models that talk about social determinants. This model that I am presenting here comes from the government of Spain, was developed in year 2010. And as you can see, you have some structural determinants of health, mainly on the social, economical, and political context. We also have some axes of inequality, mainly related with power issues. dealing with social class, gender, violence, ethnic self-identification, and the territorial aspects. But you also have these intermediate determinants where materials and resources like work, employment conditions, domestic work and care, income, housing, and residential environment are important. And this will have a big influence on psychosocial factors, behavior of the population, alongside with the biological factors and the ability of the healthcare to respond to the healthcare needs of the populations. At the end, all these structural determinants and intermediate determinants will influence the presentation of health inequities in the response of the pandemic. And let me take as an example the aspects of gender and violence as axis of inequality and the presence of power issues in the middle of a pandemic like the one that we are facing. Talking about gender and violence, more than 7,000 calls have been received by the emergency services in Ecuador for gender violence. The largest amount, 55% of these calls related to gender violence received by the emergency services are concentrated in these two main cities that are receiving the full blown of the epidemic, Quito and Guayaquil. We received more than 235 calls per day, but the problem can be worse because if you consider the mandatory isolation measures, the lockdown that was established since March, since the last month in Ecuador, many victims maybe are unable to call because they are 24 hours a day with their assailant. In the last year, Ecuador ran a family relations survey. And in this survey, 64% of women declared suffered some type of gender violence. 30% of them received this violence in their own homes. And in more than 43% of the cases, the perpetrator is the partner. So if we consider the lockdown, if we consider the isolation measures, and if we consider that violence increase when you are living with the perpetrator and increase also with economical conditions like unemployment in more than 30%, we will have a lot of calls due to gender violence just because of the lockdown during the management of this pandemic. We also need to talk about these intermediate determinants like work, employment conditions, income, economic situation, and housing. We must consider in our response to the epidemic that these two cities, Quito and Guayaquil, which are the biggest cities in the country, each of them has more than 3 million inhabitants. In these cities, the unemployment rate is 4 to 5%, and the underemployment rate is 1/5 of the population. In the last years, informal work has increased. Right now, around 46% of the population in Ecuador are informal workers. At the national level, poverty is declared at 25.5%. And poverty means that the family income is less than $85 per month. In Ecuador, we use the US dollars, our currency. And in the rural areas, the poverty is increasing. 43.8% of the population lives under this poverty threshold. So if we do not consider all these living conditions and their influence on the ability or the capacity of the families to survive and to maintain the lockdown and social distance and stop working. And if we don't adopt measures to tackle these inequities, it will be very, very difficult to reduce the transmission of this infection in the population. Another problem that you have to consider is how the healthcare system is organized. In Ecuador, we have two different ways of financing the healthcare system. We have a big public healthcare system that covers more than 80% of the population. And we also have a private component providing services to around 8% or 9% of the population. But this healthcare system is fragmented. So you have several providers giving healthcare services to different groups of the population. Most of the public healthcare services are organized depending on the employment conditions of the population that they cover. The Ministry of Health and their facilities provide attention mainly for unemployed and low-income population. You also have a proportion of the population receiving healthcare from the social security services, both from army and police, and for the former workers and their families. And the rest of the populations have to use out-of-pocket money to have access to healthcare. And this is important because right now we are facing a pandemic with a fragmented healthcare system. And this fragmentation causes lack of coordination. It's more difficult to coordinate all the measures, all the public health measures and the attention of the patients between these institutions with different logics of delivering healthcare services. And because of this overwhelming number of patients, this increasing number of patients, the public sector is also buying services to the private sector. And sometimes we spend 4, 5, or even 10 times more resources when we buy services from the private healthcare providers. And I will show this especially when we discuss about the diagnostic tests. We also have limited capacity to respond to this epidemic. Ecuador has 134 public hospitals. 22 of these are from the Ministry of Health. 5 of these hospitals providing care to the patients with COVID-19 are from the Social Security. These hospitals provide care mainly for the formal workers, and the Ministry of Health hospitals provide care for the rest of the populations. We also will include some private hospitals if we need them. And as you can see, we have limited capacity to answer to the number of patients. We only have around 1,000 critical care beds, and we only have 438 functional mechanical ventilators for adults and 124 in pediatric intensive care units. And this is information provided by the Minister of Health himself. In cities like Guayaquil, that right now have more than 7,000 cases of COVID-19 diagnosed, we only have 300 critical care beds. And most of these beds are already occupied by patients with other conditions, like myocardial infarctions, trauma, sepsis because of other pathogens. And this is the reason why, with just a little bit of more than 100 critical patients, the healthcare system in Guayaquil collapsed. And this was one of the drivers of the chaos. So in the last few days and weeks, the media around the world have been publishing shocking stories and images of this COVID-19 crisis in Ecuador. And you can see in the media scenes of corpses or dead bodies abandoned in the streets of Guayaquil, the main harbor of Ecuador. And these images have shaken the audiences in Latin America and also in other countries. In fact, the government decided to create a task force just to deal with the management of these dead bodies. A few days ago, in April 16, the government official in charge of this mortuary crisis announced that only in the last 15 days of April, in the province of Guayas, where is the city of Guayaquil, there were more than 6,000 deaths. Usually, the monthly average of deaths in cities like Guayaquil are 1.7 thousand or 2,000 deaths. And after these 15 days, it's obvious that we have a huge increase in mortality, not only because of COVID-19, but also because the lack of access to healthcare, and we have deaths because of other conditions. This is what we call indirect deaths. And this increase in deaths for COVID-19 have created really a bottleneck and prevented timely burials. And that's the explanation of all these images that you can see in the media everywhere. If we analyze the death toll due to COVID-19, both confirmed and suspected cases in Ecuador, right now we have an official number of 1,200 deaths. 478 of these are confirmed cases by laboratory tests, and more than 800 are suspect deaths due to COVID-19 based on verbal autopsies or the clinical condition of the patient before death. If we have to put these numbers in context and we analyze the historical data of the civil registry about mortality, general mortality in the country, you can see that usually in provinces like Guayas, where is located Guayaquil, the main harbor receiving the full blown of the epidemic, in the past years, let's say 2018, we usually have 1,800 deaths per month. And this trend remains during January and February. But in March, we already see an increase in the number of deaths. The general mortality in this province increased, and only in the last 15 days of April, we already have more than 6,000 deaths. And this is the explanation of this collapse of the burials or the funeral parlors in cities like Guayaquil. This is not happening in the rest of the country. In other cities like Quito and in the rest of the country, we still don't receive all the cases of COVID-19, and many of the municipalities are strengthening the lockdowns and the public health measures to contain the transmission of the disease. Another problem that we are facing is the combination of two epidemics. This phenomenon that we call a syndemic is evident with dengue. Here you can see the surveillance and the weekly reported cases of dengue in Ecuador in the last years. And as you can see, during 2020, we have a higher amount of reported cases of dengue in Ecuador just before the beginning of the COVID-19 epidemic. Once the COVID-19 epidemic started, the detection or the diagnosis and the registry of dengue cases falls down. And probably this is happening also with all the other infectious diseases, and the surveillance of the other diseases is affected because of the presence of COVID-19. There are images like this in countries like Denmark, where the surveillance of influenza cases already fall down because we are focused on managing COVID-19. And this must be taken into account also because we will face a lot of indirect deaths because we are not able to make the surveillance, the adequate surveillance of the rest of the conditions in our countries. We are too focused on COVID-19. We are providing a lot of resources to tackle this epidemic, but this will cause also a lot of indirect deaths. So right now in Guayas, you can see this syndemic, and we have also some decision or cognitive biases, because before COVID-19, most of the cases with fever are suspects of dengue or influenza. But right now, if you have someone with fever, first you think in COVID-19, despite conditions like dengue or influenza are common also. So we must take into account also these situations when we are dealing with this pandemic. Let's talk a little bit about the economic conditions and how these economic conditions have influenced the lockdown and our ability to maintain the lockdown. One of the biggest problems that we have is that there are structural and long-term problems related to this COVID-19 crisis. Countries like Ecuador and many countries in the global south are under pressure because of external debt. In the case of Ecuador, we have a lot of pressure by the International Monetary Fund to reduce the size of the state in exchange of loans. And this have caused that the public investment in healthcare fell in the last months. Only in 2019, because of these measures, there were more than 3,000 layoffs from the Ecuador's health ministry. And nearly 4.5% of the total employment of the ministers were laid off. This also will affect our capacity to answer to this crisis. The problem of the lockdown also, and if we take into account the economical conditions of the population, means that many of the companies or many of the small businesses could not resist more than 1 or 2 months of lockdown. And right now we have several economical power groups pushing for reopening the economical activities. This picture that you see was taken yesterday. And once the government announced that in the following weeks, we will reopen some of the economical activities, made that most of the population were already on the streets before the government announced officially when we are going to release this lockdown or quarantine. The government have adopted some economical measures. They decided, for example, to pay faster the unemployment insurance They are giving loans with grace periods and low interest without guarantees for small companies. They are providing a bonus for the families, especially for the people in vulnerable conditions, living below the threshold of poverty. They decided to extend the health coverage for Social Security. Even if you are unemployed, you can have access to Social Security for up to 120 days. And there is a law also that you cannot be evicted if you are delayed in the payment of your rent during the next 60 days. But despite of this, the government decided to pay the external debt, and they made a payment of more than $300 million to international banks. So we cannot explain the logic behind this. Let's talk a little bit about the challenge of developing consensus and guidelines to manage the COVID-19. As you can see, there is a plethora of non-peer review or ill peer review information outside. If you go to places like preprint websites, you have more than 2,000 preprints already there, only about COVID-19 or SARS-CoV-2. You have more than 5,000 PubMed citations from January to April in places like PubMed. And the World Health Organization Global Literature on Coronavirus have already 6,900 records in this database. And given the constraints of time, many countries are developing clinical consensus statements based on the expert opinion, with the idea to reduce the practice variations and to improve the quality of management of these conditions. And this is important because the development of clinical consensus is faster, but you have to consider also some methodological aspects. And we decided at the end to use formal consensus methods, either Delphi techniques or nominal group techniques for developing this consensus. Remember that you need to develop recommendations for all the people dealing with the disease in the first line, and you have to provide information that is readily available, easy to understand, and probably in this case, algorithms can be useful. Be careful with the content of the algorithms. If you can summarize information in tables, this can help a lot. But remember that the evidence is changing in a very fast pace, and this consensus must be living organisms, and you have to update them regularly, and most of the time you have to make several changes in just a few days. To finish my presentation, I want to talk a little bit about the challenge that we have with diagnosis. And as you can see at the beginning of the presentation, I'll show you a flattened curve. But this flattened curve is not because we are having less cases of COVID-19. It is because we do not have the capacity to run enough PCR tests and to diagnose all the cases. As you can see, all these weeks, Ecuador had a limited capacity to run diagnostic tests. Here we have a spike of 4,000 tests run because the government decided to incorporate a new PCR machine donated by one of the companies that developed this kind of PCR test. But then the machine was not working anymore, and again we go down with the number of tests. So be careful with the interpretation of the curves, especially if you don't have enough diagnostic capacity installed in your country and the availability of PCR tests is reduced. What we are trying to do to tackle this is to increase the number of private laboratories that are doing the test, but this causes also access barriers, because the government decided to fix the price and decide that the price of this test to diagnose COVID-19 goes in the range between $80 to $100 per test. If you have families living with less than $400 per month, just to run one of these tests is nearly impossible for most of them. So what we are doing now from the perspective of the universities is that we have equipment, we have technicians, but we are not accredited or licensed by the Ministry of Health to run the test. We already have calculated that we can reduce the cost of the test and increase the number of tests available at the country if we as universities are doing some of these tests. But to do this, we need to detach from closed platforms of diagnosis that use only their own reagents. So you need to start developing your own test and try to detach from these closed platforms, especially because there is a shortage of supply of all these reagents worldwide. If we can do some tests in Ecuador, you have to think at least 2 or 3 weeks in advance what reagents you need, because if you ask for the reagents today, probably you will receive them in 2 or 3 weeks' time. So that's why it's really important to increase your diagnostic capacity at the local level. And we need more research on this. These are some pictures from social media with several universities doing the accreditation process of their own laboratories. And we hope that this can help us to deal with this condition. So the main lessons to finish are: social determinants are key. Never forget them when you're planning your response, in this case to COVID-19, but also in any epidemic. It's really important to provide a specific guidelines on how to address these social determinants, how to address problems like gender and domestic violence, how to provide social support to maintain the quarantine and lockdowns, how to organize the delivery of food supplies to the underserved communities, consider economic relief measures, and prioritize public spending. It's not a good idea to pay external debt in these situations. You have to strengthen the community and local response. Do not waste time developing huge clinical practice guidelines. Probably in this scenario, it's easier to adopt or adapt guidelines, and only if you need, build some clinical consensus or protocols. And a key message also is to strengthen your diagnostic capacity, lessening your dependency on closed platforms because of this supply shortage in reagents, and because many governments are prioritizing buying these equipments for themselves instead of selling them to the poor countries. So thanks a lot for your attention. And I think we have a few minutes for questions.
Yeah, thank you. Very interesting and very striking to see how all countries face similar issues, and we all are learning while we are doing this. I'm going to have a look at the questions now and try to see how much time we have left to do so. So, of course, one of the hot topics is about the diagnostic tests. So one of the questions is, Are all tests done in Ecuador through real-time PCR, or is it an antibody test that you are doing also?
The government decided to maintain PCR as the standard test for diagnosis and also to discharge patients. We are following the recommendations of WHO on diagnosis, and the standard test is still PCR.
Okay, thank you.
But we are buying a lot of rapid tests based on serology and antibody detection, but we must be aware of the low sensitivity that these tests have, and you have to consider this when you apply this rapid test.
Okay, thank you. Then there is a question on will you use rapid antibody tests after the patients have recovered from COVID?
We did at the beginning because we don't have enough cases, but right now most of the patients are discharged based on their clinical condition.
Okay.
And only if you keep the suspicion, you do the test. We don't do it to everybody because we don't have enough tests, and we already have tests that are waiting to be processed during the last 10 days. So
yeah,
it's a problem.
In general, I think for everybody listening, we already posted on the alumni webpage a paper that was produced by Jan Jacobs on the different diagnostic tests. For the moment, there are very few antibody tests that are really validated. We don't know a lot about their sensitivity and their specificity, but we are following it up. So this document is regularly updated. So if you are interested in diagnostic tests, please regularly have a look at this document. We will try to keep it updated. But be careful, because there is a lot of tests around that are giving false information on their performance. So we have to be careful about that. Then there's a question on community quarantine centers in resource-limited countries. People that are contacted, they deny to go to community quarantine, and so because they are afraid of transmission of disease from each other. Do you, for instance, sharing the bathroom, sharing the toilet, they find it risky, and so how are you dealing with that in Ecuador?
Yes, that is a problem. The rest of the country is preparing some quarantine centers like hotels or stadiums or other facilities. But in cities with a lot of cases and a lot of social vulnerable neighborhoods, probably we are doing more quarantine of the neighborhood. And all the community, and not individual quarantines or sending patients to these quarantine centers. Mm-hmm. So in this case, probably a local response, a community response on the neighborhood is more appropriate and can help you also for surveillance of the cases that are appearing.
Okay. And then there's a question more on the therapy. One of the possible therapeutics is the use of passive immune therapy, using the convalescent plasma to treat patients. So how is the transfusion service doing that? Are they making use of that in Ecuador or not?
Yes, since the last 2 weeks, several transfusion centers, mainly those related with Red Cross, started to ask for plasma from convalescent patients to start a trial. We are going to do a trial to test the benefits of convalescent plasma for treating COVID-19.
Okay, very interesting. Many countries are starting to do that now. Yeah. And then there is a question on Ecuador. The president of Ecuador announced that the government is about to start a serological screening for antibodies in about 6% of the population. How do you see the country's capacity to carry out such a huge serological survey, and how prepared is the government to utilize these data to then make a decision?
Well, several countries are starting programs to study the seroprevalence. especially considering the high rate of asymptomatic patients. We have more than 30% of the patients without symptoms. And because of the lack of enough PCR tests, the government right now is they start already last week doing seroprevalence studies to detect the hotspots within the country and to redirect the allocation of resources to these communities with high seroprevalence of COVID-19. But this can be also useful probably when we are thinking to release the lockdown. And maybe we have to think in a combination of PCR tests plus serological tests to decide how are we going to handle this release of the lockdown.
Okay. A question, is there any problem in providing medical equipment for healthcare workers in Ecuador? And do you have many deaths among healthcare workers?
Yes, we have. We have a lot of deaths, especially in Guayaquil. Sadly, we have several hundreds of medical doctors that were infected, and many of them have died. And this was because at the beginning of the epidemic, they do not have enough personal protection equipment to work. Mm-hmm. And one of the biggest problems is the shortage of this personal protection equipment worldwide. Mm-hmm. So we are trying to prioritize the delivery of this equipment to the healthcare professionals, but still many of them are working in conditions that are not the ideal.
Yeah. And then a question about the how the health system is reacting, because you have a very fragmented health structure in Ecuador. Is this something that is now being discussed in the country? Are there other approaches? We also see it in Belgium. Certain things become suddenly possible. We can now do online consultations. Are there attempts to standardize diagnosis and treatment approaches across the different fragments in the health system?
Yes, one of the ideas to standardize treatment is that the National Emergency Committee ask professionals to develop these consensus guidelines. And these guidelines are the official guidelines across the country to handle the cases. The problem is that many of the healthcare facilities do not have the same amount of resources. You have a lot of inequities in the capacity to respond to the care of the patients. And also the fragmentation of the healthcare systems do not allow the referral of patients from one system to the other. If the crisis gets worse, probably the government will be in the necessity to use the private hospitals and probably to make them available to treat all the patients and not use just the public healthcare facilities.
Okay, and then a question about to understand better the epidemic curve in Ecuador. Wouldn't it be possible to just do serology tests to see better, to know better how is the epidemic going on, than do a PCR?
That's the idea from the government. They are already starting to do a massive serological tests. But remember that you also have a low sensitivity and the diagnostic performance of this serology test change depending on the time of the infection. Mm-hmm. You have a lot of false negatives at the beginning, and then you cannot rely just on this test. Probably a combination of clinical symptoms, epidemiological factors, social factors, and serology tests can be a better approach.
Mm-hmm. Okay, thank you. And then a question about community participation. like for instance, help other people, a social anchor. Are they being employed in terms of reducing the burden of the social determinants? Is there any volunteer group? How are you dealing with, for instance, the next question is about vulnerable populations. Are you doing something specific with them? Or with migrant populations, for instance, people from Venezuela who come to Ecuador? So how are you dealing with those groups?
Yes, community participation was weakened during the last years in Ecuador. Many social organizations were eliminated during the past years. So now we are having problems with social participation at the country. The Ministry of Social Affairs is trying to help vulnerable populations mainly through a bonus to the poor families. And you also have a lot of private groups trying to help these vulnerable populations, but we still see a lack of coordination. The coordination of the response is not good enough.
Mm-hmm. Okay. Does Ecuador have the capacity to do CT scans in the diagnostic process?
Only in the main cities.
Mm-hmm.
The number of CT scans is very limited across the country. And in this case, probably simple chest X-rays can help also to provide some information especially in the severe cases.
Mm-hmm. Okay. And then a question that is bothering all of us. We are all in lockdown and we are wondering how long is this going to last. And so the question is, do you think Ecuador will apply a kind of accordion effect in and out of lockdown for the next year or two? And does that make sense?
Yes, the strategy that the government is trying to apply is to use some kind of semaphore with red, yellow, and green lights, depending on the increase or reduced number of cases that are detected. But this will rely heavily on our capacity to diagnose cases.
Mm-hmm.
If we don't have enough tests to do, and if we don't have the capacity to run tests on the population, it's useless to use this kind of semaphore approach. And probably what will happen is that we are going to release the lockdown and we will face a surge on the number of cases in the following weeks immediately after the release of the lockdown. Mm-hmm. And probably we will go again with lockdowns on and off during the next months.
Yeah. And then a question that we didn't talk a lot about treatments is Ecuador involved in a trial, for instance, a question specifically on the hydroxychloroquine trial. Are you involved in that, or is Ecuador not conducting clinical trials?
We start conducting some observational studies. The government already asked to be involved in some of the multi-center clinical trials like Solidarity 1 and probably Solidarity 2, but they haven't started yet in Ecuador. And we are planning also a clinical trial on the use of convalescent plasma for the treatment of patients. But one of the biggest problems we have right now in Ecuador is that the restrictions and the laws regulating clinical trials are not good enough. So this is where we need more cooperation or international cooperations to run some of these trials. In fact, in Ecuador, we are using chloroquine and hydroxychloroquine a lot, but still we don't have results on the effects of this treatment. And probably it's useless, given the last publications on the performance of chloroquine or hydroxychloroquine.
Okay, thank you. And then questions on epidemiology. Is it different for the indigenous populations that live in the Andes?
We face two problems. So far, the indigenous populations living in the Andes are not having a lot of cases, but many of these communities made a lot of trade with the population living in Guayaquil. So probably what we are going to face in the following weeks is an increase in the number of cases in the indigenous populations living in the Andes because of the trade relationship with the coast. But there we have a weak surveillance system. So what will happen, I think, is that we're going to have a lot of deaths that go silent and are not diagnosed as COVID-19. So we have to increase our surveillance in those populations.
Okay. And do you also have a problem in your country with the retirement homes for old people? Because that's a big problem in Europe.
In this case, we are different from Europe. Yes, we have an increasing number of elderly population, but we do not have a lot of long care facilities or long-term care facilities, and we don't have a lot of residencies for elderly people. At the whole country, we have 1,800 elderly living in this kind of residences, and we're going to start next week with some massive tests in that population, but we don't face the same problem that Europe regarding elderly population.
And then there's a question on whether mild cases should not be admitted also, because in order to control the transmission, because many of them, if you send them home, it will be difficult to respect the isolation or the quarantine measures at home with few rooms and a lot of family members.
Yeah, and that's one of the biggest problems. If you have many people living in small spaces, the transmission will increase, but also you have the trade-off that you don't have enough healthcare facilities to take care of this population. So probably what will happen is that we're going to have a lot of infections within the households. The transmission rate will increase within the households because we don't have enough facilities to do the isolation of these patients.
Mm-hmm. Is Ecuador putting anything in place to get a better idea on how many people actually die from COVID instead of just making it suspect deaths?
I don't know. What we are doing now is trying to cross information between the civil registry, because you have compulsory inscription of deaths to allow the burials, and cross this information with the number of cases diagnosed in every province. Monitoring this can help to have an idea of the number of deaths, but you don't know how many of these deaths are attributable to COVID-19. Many of these deaths will be indirect deaths because of lack of access to healthcare.
Okay, thank you. I think it was really interesting, Rodrigo. Thank you very much. We are 10 minutes late. I would like to round up the discussion here. Thank you all.
Thanks a lot, and stay safe, everybody.